So what this is a brief review of some protocol changes we're going to be making this month. So these is a protocol update for June 2020. The reasons we're doing this is, first off, COVID-19 has really driven a lot of what we've been doing over the past 3 months, and it's really the primary driver for having this update in June. We have taken some materials that I distributed in early March as a memorandum that was an addendum to the protocol, and we've taken those changes, made some modifications, and moved them into the primary protocol under which we operate. We also are taking this as an opportunity to revise our clinical standard on consent, refusal, treatment, no transport. This really was a revision we made in December for this year. However, when the protocol came out, the principal changes that we made failed to show up in the protocol, so we're adding them in the protocol, but 6 months late. There have been some questions over the past months about the epinephrine for infusion and for push dose therapy as it relates to DSI and for general use in our patient population, so we've made some clarifications there. And finally, we have added a section, the reference section, on veterinary first aid for dogs and cats. And this is based on changes to the Ohio Revised Code several years ago that allowed EMS providers to provide some limited care to ill and injured dogs and cats. We anticipate that these revisions to the protocol will be released as a protocol update or a revised protocol on the ResponSoft app sometime during the week of June 22nd. So moving on, like I mentioned, everything has been driven by COVID-19 over the past months, and what we have done is we've looked at the changes I put in place as part of my memorandum dated March 27th, 2020, and moved them into the protocol and made them mainstream. So what we did in March as part of my memorandum, there's a request that we avoid BiPAP, CPAP, and nebulized medications as much as possible. We know that COVID is principally transmitted via droplets, and it can be aerosolized by doing airway procedures, so we have an interest in avoiding these procedures or at least reducing risk. We also indicated the iGel was preferred over the endotracheal tube. There was an emphasis on no use of Decadron, particularly for patients who may have COVID, and made a statement that intramuscular epinephrine and IV magnesium sulfate was preferred over nebulized medications for bronchospasm. So in the 4 months since this memorandum came out, we have learned quite a bit. I think we've all become comfortable, or more comfortable, I should say, managing patients who may be infected or are documented to be infected with COVID-19. We have our 911 call takers screening all of our calls to identify high-risk runs. We are using PPE. We're more comfortable with PPE, and I believe PPE is much more available now than it was 3 to 4 months ago. I think we've also become much more aware of high-risk populations, and those really for us have become the extended care facilities, nursing homes, and so on, corrections facilities, group homes, or patients with previous exposures or have had document exposure to someone in the family or at work with COVID-19. We also now have a much more organized and reliable process to evaluate ill providers who may have or may not have COVID-19, and we've gone from testing turnaround times of well over a week to well under 1 day. So we have a better process to quickly determine whether or not our providers are ill with COVID or not. But we've also discovered that asthma, CHF, COPD, and other drivers of respiratory illness have not gone away. It's now June. We're moving into the peak months for asthma and COPD exacerbations. So we have to look at what group of patients can we use nebulized medications for because they most likely don't have COVID versus those patients that more likely have COVID, and if we can minimize aerosolization of saliva and mucus and so on, the better off we will be. So what we've done is we've developed a new section that will go into the protocol, and to a large extent takes my memorandum of March 27th and moves it into protocol. So this is a new section. It's going to be interfaced between the preface section and the adult procedures. It's going to be called infectious airway / cardiac arrest, and it's really a process that we want to use for all of our patients. But it also, by using this, allows us to discriminate between patients who most likely have COVID-19 versus patients who have respiratory symptoms but more likely have some other illness such as asthma or COPD or CHF exacerbations. So this is what you will see. And like I mentioned, this will supersede the memorandum of March 27th. So when the new protocol comes out, the memorandum will be revoked. And it will then be in place in our protocol. I like to emphasize this scene size up. So we go in to see a patient, and we have our appropriate PPE on, and we have our precautions in place. But we do this scene size up for all patients. That's standoff assessment. So during that time, we determine what our resources needs are. Do we need all of the staff members in the room, or can we back off and only have 1 or 2 providers in with the patient? And then how much PPE do we need? So if this is a high-risk patient, then we need to be fully gowned up and have airborne procedures and protections in place. If it's unlikely this patient is at risk or presents risk to our providers for COVID-19, then we can keep our standard precautions on, but move on and take care of the patient. So in our general approach to our patients, we're going to put masks on all of our patients, and that will continue until we have a reason to discontinue that. Yes, the patient may have sprained their ankles, but they still could be a potential source of COVID. We are going to use our own PPE, which should be gloves, a surgical mask, and some type of eye protection for all patient encounters. We're going to perform that standoff assessment. If the patient seems to be high risk, then we're going to don airborne PPE, which means we're going to have better eye protection, which would either be goggles or a face shield. We'll have an N95 or a better mask on. And we're going to do this for all cardiac arrests, all patients with confirmed or suspected COVID, and during any procedures that we perform that might generate aerosolized secretions. That's predominantly airway procedures and nebulized medications. So that's how we're going to approach all of our patients. Looking at the algorithm at the top of the algorithm, there are 2 boxes. On the top left, it says possible airway or infectious airway. And these are what we've identified as some quick screening criteria. It's not meant to be comprehensive, but it should cover the high points and the high risk features. So does the patient have a fever? Do they have a cough? Are they dyspneic? Do they have a recent diagnosis of COVID or other highly infectious disease? TB comes to mind. And are they in a high-risk environment, such as a ECF or skilled nursing facility? Are they in prison, or have they been recently incarcerated? Or do they reside in a group home, or are they a healthcare worker? We've had at least one exposure of our EMS providers to a coworker who turns out to be a COVID positive patient. So U.S. healthcare workers are considered high risk for this illness. So any healthcare worker with fever, cough, or any other features to suggest COVID would be considered a high risk patient. For all patients, as the box on the top right of the algorithm says, we're going to wear a surgical mask on the patient and crew. We're going to obtain vital signs as part of that standoff assessment or shortly thereafter. If we have to use airway procedures, we're going to put a HEPA filter on the tube, or we're going to use a BVM that has a HEPA filter in it, and I've got a slide with some pictures. So essentially, if the patient needs to be ventilated with a BVM or an iGel or an endotracheal tube, we're going to put an inline HEPA filter in place, or we're going to have a BVM that has a filter in it. Again, that's to catch the secretions during exhalation. We know that these devices are on back order through many of our suppliers, but I've asked our EMS coordinators to put orders in for the necessary equipment, and when they become available, then have it delivered. But we need to start protecting ourselves and others from these aerosolized secretions. If the patient needs a nebulized treatment, we need to transition to an AeroEclipse or similar device, or a nebulizer that has a viral filter on the exhaust tube. So the AeroClips is basically a nebulizing device that only activates during inspiration, and it doesn't release patient secretions out into the air. We could also or can find nebulizers that have a viral filter on the exhaust tube. Again, the idea being that as the patient exhales through the tube, any infectious material is caught by the filter. If you go to the bottom part of the algorithm, at the bottom you've got that decision point. There's a possibly infectious airway, or if the patient's in cardiac arrest. If the answer is yes to either of those, then we're going to follow the appropriate protocol. We're going to use airborne precautions. If the patient is awake and is able to use or self-administer their own albuterol via an inhaler, they can do that, and you can assist them doing it. And they can take 1 or 2 puffs every couple of minutes as they need. If the patient is hypoxic and you think they have COVID-19, it's been shown that high flow oxygen with the patient in a prone position helps oxygenate the patient, and it reduces the risk for other airway procedures. I covered that as part of one of my COVID talks. Still would like to avoid steroids at the hospital. They may decide to give the patient steroids, but that's for the hospital to decide. Again, if we have to put an advanced airway in place in a patient who's at risk for COVID or any other infectious respiratory ailment, the iGel is preferred over the endotracheal tube. If you need to put an endotracheal tube in, then use as much protection as you can, and that could includes things such as putting a clear plastic drape over the patient's head to help keep secretions from being aerosolized into the room. We would like to avoid CPAP if possible. If you have to do it, again, you've got to be fully protected with PPE. Keep in mind at the hospital when we do airway procedures now, when we nebulize meds or put a patient on CPAP or BiPAP, regardless of the condition, that patient's in airborne precautions, we put on the appropriate gear to protect ourselves. We make the presumption that every patient with an airway procedure is COVID positive. And then if you think the patient's got COVID, we continue to think about using IM epinephrine and IV magnesium sulfate for bronchospasm. Now, if on the other side of the algorithm you think it's very unlikely the patient's got COVID, you think this is a CHF exacerbation, the patient's gained 10 pounds in the past week, they have orthopnea, they've got neck veins up to the angles of the jaw, they've got peripheral edema, okay, looks and smells like CHF, treat them like CHF per the usual protocol. If you think they've got a COPD exacerbation or asthma exacerbation, treat them per the appropriate protocol. Again, if you have to use or have to provide any airway interventions, whether that's aerosolized meds, CPAP, BiPAP, or intubation for these patients, upgrade your PPE to airborne. If you're doing any of these procedures, protect yourself. The difference here is that if you think it's more likely CHF, COPD, or asthma, you can follow the treatment program or algorithm that's appropriate for their condition, but you still have to protect yourself with the appropriate airborne precautions. So I've talked to them about reducing aerosolization. Another thing I mentioned was transport, non-transport changes. You know, we have our consent refusal treatment clinical standard, and we made some changes to it at the first of the year, but it just didn't get in line with, was not placed in the protocol that you received. So we went back and took this opportunity to look at it to make sure we liked what we had, and we have added the missing paragraphs to the procedure, but we've made some mild modifications, which included a checklist for patients you do not transport. I just want to make sure we're clear on definitions. This clinical standard concerns or covers patient refusals as well as no transports or non-transports. For definitions perspective, a refusal is a patient who has a illness or injury for which you as an EMS provider think the patient needs to be seen by a provider, by a physician or advanced practice person. They need to go to the hospital. You've explained this to the patient and the patient declines transport. So that is a refusal. The patient has a need to go to the hospital, they have the capacity to make an informed decision, and they make the decision to decline transport. That is a refusal. No transports, non-transports are patients who have a low acuity illness or injury. It is determination by the EMS provider that the patient does not need to go to the hospital and does not offer transport. That is a non-transport. So if the patient refuses transport, that's a refusal. If you don't think they need to go, that's a non-transport. Patients who refuse have to sign the refusal form. Patients who are not transported do not sign the refusal form because they're not refusing something you didn't offer. So that's the difference. We put an algorithm in place. This is new to what we're going to put in, and which I talked about as part of the protocol update for 2020. This is basically a flow sheet. So in the center on the top it says, does the patient require treatment and or transport? If the answer is yes, you take the arm to the left. If the patient has a condition that does not require treatment or transport, you can take the arm to the right. So if you go to the left, a patient has a condition, they're having chest pain or whatever, and you think they need to go to the hospital. If the patient has the capacity to make an informed decision, and do they meet the criteria of the refusal of care checklist, which is on the next slide, then you have the patient sign the refusal form and you leave them on the scene. So that's the bottom left. If the patient doesn't have the capacity or the patient doesn't meet the criteria outlined on the refusal checklist, then you take them to the closest facility. On the right-hand side, if the patient has a medical condition that does not require transport to the hospital, and the patient does not have the capacity to make an informed decision, we're going to take them to the hospital. So if you have a patient with a non-life-threatening, not limb-threatening condition, but they just don't understand what's going on, you're obligated to take them to the hospital. That's in the patient's best interest. However, if the patient has the capacity to make an informed decision and the patient meets the criteria on the non-transport checklist, which we'll see on the next slide, then you leave the patient behind. They don't need to sign any forms. If the patient doesn't meet the criteria of the checklist, then we want to take them to the hospital. So here are the checklists. On the left-hand side, it's the refusal checklist. This is the same checklist that's been in the protocol, and it's got the same elements. The patient has to be old enough. They cannot be having homicidal or suicidal ideations. They have to have the capacity to make an informed decision. They understand that there are risks involved, you've talked about all the other things in place. So the patient gets appropriate advice, patient gets given information for follow-up or when to call back, there's appropriate documentation, and the other items on the bottom left on the checklist in terms of evaluating capacity is in place. On the right-hand side, for the treat and or no transport checklist, these are the patients you don't think need to go to the hospital. So the patient assessment says that you've evaluated the patient and you've reasonably excluded any significant illness or injury. The patient's able to get up and around normally or at their baseline. You've got a plan. The patient has a plan for follow-up. Sometimes that's something you have to work with the patient on. Patient says, where can I go? And you say urgent care. Okay, the patient can go to urgent care and you don't transport. The patient is able to provide self-care or has somebody with them who can provide self-care. So if the patient's not able to care for themselves, we really don't want to leave them alone or in an unsafe circumstance. Keep that in mind. And then we've listed 6 conditions which really I don't think should be seen as opportunities to leave somebody behind as a non-transport. Somebody with acute abdominal pain needs to be evaluated. Someone who falls and is on high-risk anticoagulants, so the antiplatelet drugs, aspirin or Plavix, more so Plavix than aspirin, or any of the anticoagulants, whether it's Xarelto, Coumadin, Eliquis, Pradaxa, any of those, those patients need to be evaluated, particularly if they have head injury. Any patient with a fever under 5 or over 70, those patients need to be evaluated, and this parameter is in line and consistent with our COVID plans as well. Anybody who's got acute non-traumatic back pain, so we're not talking about somebody who lifted a 40-pound sack of fertilizer and hurt their back, somebody who twisted wrong. We're talking about somebody who has acute low back pain or any back pain with no evidence of injury, not able to identify injury. These are the patients we have to think about things like spinal cord disease, spinal cord compression from abscess, abdominal aortic aneurysm, dissection of the thoracic aorta. So these are patients that have high-risk features, that are high risk for bad things, and typically they have acute back pain without history of injury. Also, if a patient has episodes of syncope or they're complaining of syncope or vertigo, they need to be evaluated. Vertigo has become harder and harder to evaluate as we become more sophisticated with imaging. So more and more patients who have vertigo, we have to evaluate to see if they have any evidence of stroke involving the posterior circulation of the brain, meaning the brain stem and the cerebellum. So vertigo is a difficult evaluation, and I don't think can be adequately evaluated in the field. Syncope, the same thing. If somebody passes out, is it an arrhythmia or something else? One of the medics today had a patient who had a syncope episode while jogging, and she was young and healthy, but she was also in VTAC. So we have to exclude arrhythmias as part of our syncope workup. So they need to be offered transport to the hospital. I think that's it for non-transports. The next has to do with epinephrine. And these are just some cleanups on epinephrine. We have epinephrine's been in our protocol for a long time, but we have placed some additional emphasis on use of push-dose epinephrine and epinephrine infusion for hypotension. So there are some questions asked with the last release of the protocol, and we're taking this as an opportunity to kind of clarify those. So on DSI, we have epinephrine listed in the DSI protocol to manage hypotension before we start administering other medications or managing the airway. So what we did is we basically clarified this first line. It's always been in the DSI protocol, but it wasn't clear enough. So we clarify it to say that we use epinephrine as a push dose to correct hypotension. Some providers took this line as it was previously worded to mean everybody gets push dose epi before they get drugs. No, patients get push dose epinephrine if they are hypotensive, and we are going to provide an artificial airway. So that's the circumstance, and we also we're a little clearer on how to dilute it and so on. And it also makes reference to the epinephrine infusion, and there'll be a link that takes you right to the infusion page. We also looked at the epinephrine push dose versus infusion, and both of them use the same dilution base. Both of them use the 1 to 100,000, but we separated the two so just for point of clarification. So push dose epinephrine is 1 to 100,000. We take 1 milligram of epinephrine, put it in a 100 cc bag, and that gives us the dilution that we use either for the infusion or the push dose. So we separated it just so there's clarification. If you want to know what to do for push dose versus what's the protocol for infusion, they're separate, distinct pages now. Did that as a point of clarification. Same thing for the epinephrine infusion. We put a clarification with instructions on how to dilute it, and we also have the epinephrine drip table as part of the infusion protocol. And there are hot links that will take you directly to the epinephrine drip dosing table. One thing that I've been asked and we have not gone with at this point is, can we just take some 1 to 10,000 epinephrine and mix that with some normal saline in a syringe and come up with a similar dilution? And for now, we're not going to do that. It's not a bad idea. It's just we're trying to keep it simple and avoid confusion. We don't use the epinephrine push dose or infusion very often, and I felt that if we added yet another way to do this, we would just cause more confusion. So this is not a bad idea. It can be done where you mix 9 cc's of normal saline with 1 cc of 1 to 10,000, and you get the same dilution as if you put a milligram in a 100 cc bag. It may be easy for many to do, but I'm just concerned about the confusion. We've also had some issues getting 1 to 10,000 epinephrine, and to my knowledge, a vial of 1 to 1,000 epinephrine and a 100 cc bag of saline is still considerably cheaper than using one box of 1 to 10,000. So we're going to stay away from that now. We'll revisit it next year. The last thing that we made is we added a section under the reference section regarding veterinary first aid. So this is something we've done to a large extent at the request of our TEMS folks because sometimes the canines will get injured on the scene. But a couple years ago, the Ohio legislature passed Ohio Revised Code 4765.52, which basically says that EMS providers can provide medical care to a dog or cat, and that's all it's limited to. You can't do turtles or birds or snakes. I'm talking dogs or cats. And it's very specific about what you can do. So this is what's in Ohio Revised Code. This is law. This is not something that the MFATS board can revise as an administrative rule. So you can manually open and maintain an airway. You can give mouth to snout or mouth to mouth ventilation using a barrier device. You can administer oxygen in any way you want to, whether it's those masks that go over the snout or whatever. You can manage ventilation by way of a mask. You can control hemorrhage with direct pressure. You can immobilize fracture. You can bandage. And you can administer one medication. The only medication that you're allowed to administer to an animal is naloxone. So we have added that to this section, and there's a dosing schedule there. In terms of dosing for dogs, the average working dog, which is our primary focus, 4 milligrams of intranasal naloxone should be fine. So you should just use what you use for adults. So that's what we have, and that's what's in place. And this is something we can do as long as it's in the protocol and it has at least been reviewed by a veterinarian, and a veterinarian has reviewed and provided the protocol. So it will be added to the reference section. It has a portion of this first aid section. It has to do with the basic assessment of animals, cats and dogs, and vital signs. To me, one of the most important things is you don't approach a working dog unless it's appropriately muzzled, particularly if it's injured. Excuse me. There are some things for disease and injury-specific care, such as administration of Narcan or oxygen. And there's identification of, I believe, 3, if not 4, 24/7 emergency veterinary care locations where animals can be transported. Currently, we're working on training opportunities. I think a lot of what's in the protocol is some things you already have knowledge to do. So, if something is, if you have a wound, you know how to clean it and dress it. You know how to administer Narcan. You know how to administer oxygen. I don't think there's anything in there that's a surprise. The Ohio Revised Code does not allow things such as IV fluids or intramuscular medications to animals. There's nothing in there about doing CPR on an animal. It's pretty much specifically as outlined on the previous slide. And it's my understanding the Veterinary Medical Association really insisted on what was in the law, and the legislatures didn't go above and beyond what the veterinary group asked for. So more to come on that, and as we develop training opportunities, we'll let you know. That's what we have. Hopefully you haven't fallen asleep. I appreciate any feedback or follow-up. You send me your emails or post your questions directly on Workplace. Thank you.